Yeah. So good morning and good afternoon. So for our very loyal audience of the ICC, thank you for coming again to join this online meeting. We always provide a better and more well-organized cleft management for our patients. So today, our topic, we invited Dr. Chun-Lin Su to present a special topic, and this topic is focusing on the patient with the cleft and the receiving the two-jaws orthognathic surgery. We care about the speech function for those patients with the cleft. So that will focus on the velopharyngeal function after the OGF surgery in the cleft patient. And Dr. Chun-Lin Su will provide some scientific data and some very comprehensive information for us. And we all invited all of your comment with us. And by the way, because the COVID so far I think, is not so serious in all over the world, we have managed one of the website, and we have a questionnaire. I would like to invite all of you to give us some feedback and comment. So I need 1 minute's time to invite Dr. Gloria to introduce this questionnaire in the very first beginning. Yeah, please, Gloria.
So hi, thank you for introducing me, Dr. Cho. So hi, hello, I'm Gloria Chen, or just Gloria is fine. So just as Dr. Cho mentioned, since 2020 we started the International Craniofacial Club webinar. Well, without a choice due to the pandemic, and it's been nearly 2 years of holding webinars once every 2 weeks, and this is our 45th webinars, which I think we can all agree that we've made quite a progress. We're hoping that this community could grow and provide an even better platform for surgeons and physicians in general. So if you're ever felt like there's something that needs to be fixed or needs to change while attending our webinars, well, this is your time. It will be very much appreciated if our viewers online don't mind giving us a few moments of your time so that we might gain a better understanding of how the ICC webinars are working, and also how online meetings and webinars has changed between pre-COVID and now for everyone. By inviting you guys to participate in a short survey. The link to our Google form will be posted in the chatting room and also on our Facebook group page. And we will be looking through all the feedbacks individually. We hope you know that we understand every point of view and value everyone's opinion. So if it's possible, you could head right over to the questionnaire now or after the webinar today and fill out a few multiple choice or like yes or no questions, and that's it. It really will mean a lot to us. Thank you so much for your time. We will look forward to hear from all of you.
Okay, thank you, Gloria. Yeah, so later the link for the questionnaire of the ICC will be posted in our chatting room. And after the presentation, I think our co-moderator, Dr. Junior too, will give us one more repeat about the importance of the questionnaire later. So I can wait to invite our presenter, Dr. Chun-Lin Su, and to give us the special topic. So please, Dr. Su, please share your slide first.
Okay. Uh, so can you see me on the slide?
Yes, good.
It's okay. Yeah.
Yes,
Okay.
good.
Okay. So good evening. I'm Chun-Lin, and I'm a fifth-year resident in the plastic surgery department. And today I'm gonna talk is the velopharyngeal function change after orthognathic surgery in cleft patients. So first, I will introduce some backgrounds of this topic, and then I will bring up our scientific studies. So the normal velopharyngeal function. So the first figure shows the structure of the roof of the mouth. and there are hard palate and soft palate. And the velopharyngeal valve is very important for normal speech production. And the valve is made of the structures, including the velum, which called soft palate, and the lateral pharyngeal walls and the posterior pharyngeal wall. And the second figure shows the velum resting against the back of the tongue for nasal breathing. And this allows the air that is inhaled through the nose to go through the throat and to the lungs and back up again. And the figure on the right side shows that how the velum closes against the back wall of the throat during speech. So the side walls close against the velum so that all of these structures come together as a valve. And when the velopharyngeal valve closes, the air and the sound are sent into the mouth for the speech. So the velopharyngeal insufficiency is usually caused by the abnormality of the soft palate, and it's really common in the cleft patients and the submucous cleft. And the reason is that the velum is too short for the velopharyngeal port closure. And the VPI, the symptoms include a hypernasal speech, which means that the speech has a high nasal quality. And second is the increased nasal resonance, which means the sound energy traveling through the nose and mouth. And the next was the nasal regurgitation, which means that sometimes the foods come out of the nose. And finally is the nasal emission during speech, which means the air escapes through the nose during speech. And the figure shows that when the VPI, the velum is too short to close the velopharyngeal pores. So when we do in the speech, the air not only go through the mouth, but leak to the nose. So for the VPI grading in our center, we have three grading, which was the adequate, marginal, and inadequate. And our function evaluation was based on the two evaluation. One is the perceptual and another is the instrumental assessment. The perceptual assessment, we will evaluate the resonance when it was normal to consistent, or just the mild hypernasality will be the adequate. And when is mild to moderate hypernasality will be marginal velopharyngeal function. And when it's severe hypernasality will be inadequate VPI. And for the patients with marginal or inadequate VP function, we will did the MPS, which was the instrumental valuation. So when the closure ratio was ranged from 0.7 to 0.95 will be the marginal VPI, and when the closure ratio was less than 0.7, it will be the inadequate VPI. And for the treatment protocol, this figure is also from the Professor Low's paper, and it concludes the treatment course, the treatment protocol of the VPI in our center. So when the VP was adequate, we would just need a regular follow-up for the possible change. And when it was hypernasality noticed by the perceptual assessment, we will arrange the instrumental assessment by the MPS. And when the closure ratio was shows the marginal VPI, usually we'll do the double apposition Z-plasty, furlough palatoplasty. And when the VPI was inadequate, we in a not really bad closure ratio, sometimes we would also do the furlough, or mostly we'll do the narrowing pharyngeal flap. And when the closure ratio was really bad, we will do the wide pharyngeal flap. And there were 3 time points we need to check the VP function. The first was the initial VPI, which means that the patient underwent the palatoplasty, and then he grows up, and before the preschool age, this time point we have to evaluate the VPI. It's the first time point. And second was the pre-OGS, and the third was the post-OGS. And in the initial VPI after the treatment, such as the first VP surgery or either the speech therapy, the initial VPI may be improved or just keep the same. And at a pre-OGS VPI, we also know that the OGS might deteriorate the VP function, which means that when the patient doesn't have the VPI, he will develop the VPI after the OGS. And if he had VPI, he had no chance to get improved. And if the post-OGS VPI was noticed, and usually the second VP surgery is needed to correct. But there's a interesting situation is that the patient has VPI, but after the OGS, the VPI was gone. And it's really interesting topic, and we have some cases and we will discuss it later. So the VPI after OGS was mainly caused by the mesothelial advancement. And usually in our center, we do the level 1 osteotomy. And it's a most common procedure to correct the mid-face retrusion in cleft patients. And the pathophysiology is that the maxilla was advanced and the VP port was widened. So the previously short balance will become more and more difficult to code the VP port. And this study was meta-analysis and in 2021, and the conclusion is that the effect of maxillary advancement on speech and VP functions remain controversial in cleft patients. So this topic was discussing. First, we want to discuss the VP function change after OGS. In the previous study, the rates was ranged from 8 to 36% of patient, they will have the VP worsen after OGS. And most of the study mentions that the OGS had a negative impact on VPI. However, there's still some few studies say that OGS was not a significant risk for the development of VPI. And then how about the maxillary advancement, which means the anterior posterior movement of the maxilla? A study in 2004 said that the maxillary advancement has a negative impact, but they don't provide any statistic. And in the early times in 1998, this study says that they do the one-jaw surgery, and it says that the high risk of VPI if the maxillary advancement was greater than 10 millimeter. And in a recent study by Chang, they found that the stable range of maxillary advancement from 1 to 5 millimeter for speech safety. In their study, if the maxilla was advanced 6 to 8 millimeter, it will have greater risk to develop VPI after OGS. But most of the study said that they didn't find any significant correlations between the OGS and the VPI. And for the risk factor, it was a great topic that had been widely studied previously. And the most things they found was that the borderline VPI before the OGS, and the other was the pre-OGS valent length. It was the major risk factor for the development of the VPI. And also in 2005, a study by Chang pre-OGS VP function assessment, including the perceptual and also the scope evaluation, is very critical to predict the VPI. And in our center in 2020 by Dr. Yao, we developed a study and we found that the limited maxillary advancement and also the clockwise rotational movement of the MMC is 2 factors to prevent the VPI. So we will bring our study. We developed our study based on 162 cases. So what's the research gap? In the previous literatures, most are the small case numbers, and mostly they did isolated level 1, which means a one jaw. And also they have different races and different VP evaluation methods. And most importantly, the results were still controversial. And we want to know how much we advance the maxilla will deteriorate the VP outcomes. So our study was aimed to evaluate the VP function changes after 2-gel OGS in cleft patients. And also we want to assess the risk for VP function worsen. So we collect the patient from 2015 to 2020 in a 6 years period, and it's a single institution and single surgeon study. The surgeons was the Professor Lunzhou, and we include all the patients, a cleft patient receiving the 2-gel OGS, and we exclude the patient who has a reduced OGS, who is syndromic, and who is not ankle cleft femur occlusion. Follow-up time was at least 6 months. So in this 6-year period, we totally, Professor Low had 229 cleft OGS, and after inclusion, and finally we have 162 patients. So we collect the demography, including age, gender, cleft type, pre-op VPI and grading. And also the intraoperative data was collected by the 2D lateral cephalometry, including the maxillary advancement by the point A and mandibular setback by point B, and also the pitch rotation of the maxilla. And our outcomes include the post-OGS VPI, post-OGS VP surgery, and the complication of obstructive sleep apnea. Our VP assessment was mostly by perceptual assessment, just like I just mentioned before, which was great to have 3 grades, adequate, marginal, and inadequate. And also some instrumental assessment was be performed selectively. When the patient has the marginal or inadequate VPI on the perceptual assessment, we will do the NPS for the patient to evaluate the closure ratio of VP port. And the MMC movement was based on lateral cephalometry, and the point A and point B had 2 vectors. The horizontal vectors was parallel to the FH plane, and the vertical vector was perpendicular to the FH plane, and the pitch rotation was calculated by the difference of the occlusal plane. And the first table shows the patient demography and pre and peri OGS data, and 54% of patient has the unilateral cleft, and 31 was the bilateral, and 13 was isolated cleft lip or cleft palate. And about 25% of patients ever received the previous VP surgery in their preschool age. And the pre-OGS VP function is adequate in 80% of patients, and it was marginal in 70% of patients, and 2.5 patient was inadequate VPI. And our mean maxillary advancement amount was 3.3 millimeter, and mean mandibular setback amount was 4.5 millimeter. And the pitch clockwise rotation was 3.9 degrees. And the table 2 was the post-OGS outcome and complications. And after the OGS, 80% of patient has unchanged VP function. However, 14% has the VP worsening. And interestingly, there were 6 patients, which is 3.7%, have the improving VP function after the OGS. And the complications including infection and plate exposure and bone knotting. And what I have to mention is that 4 patients developed a sleep disorder after OGS. 3 was snoring and 1 was OSA. And after the OGS, about like 20% of patients needs the secondary VP surgery. And this figure shows that the change of the VP function after OGS, and the X was the pre-op VP function, and the Y was the post-OGS VP function. And in our pre-OGS, most around 80% of patients develop the function worsening after OGS. And in the pre-OGS marginal group, mostly stay the same, and about like 10% of patient has a VP function worsening, but there were 20% has the VP function improving after the OGS. In our pre-OGS inadequate group, mostly patients stay the same. And the statistics shows that the pre and post OGS change has the statistical significance. And this table, we use the logistic regression for the velopharyngeal function change, velopharyngeal function worsening after the OGS. We put the factor to the model. We found that the mesothelial advancement is an independent risk factor for VP function worsening, and which was the statistical significance. And based on this, we do the ROC curve for the prediction of the VP function worsening based on the amount of the mesothelial advancement. And this ROC curve shows that the AUC was 0.727, and it was not bad. And also the Uden index was 4.27 millimeter, which means that this magic number was the cut point to have the maximum sensitivity and specificity to predict the VP function worsening after OGS. And then we just, based on this number, 4.27 millimeter, we grouped the patient into two groups, and we found that when the mesothelial advancement was greater than 4.27 millimeter, and they may have the poorer VP outcomes and also a higher post-OGS VP surgery rate. So the VP function change after OGS. We found that the negative impact of OGS on VP function in cleft patients. The pre-OGS and post-OGS VPI rate was 19.8% and 27.2%, and which has the statistical significance. And this finding was similar to most of the previous literature. And we think that this result was related to the increased VP port after the mesothelial advancement. And then the mesothelial advancement and the VP worsening, we think that the VP function change after OGS was multifactorial. The first was the factor of anatomy, which means the VP pore space. And in this study, we found that when the mesothelium was advanced greater than 4.27 millimeter, it has a higher risk to develop VP function worsening after OGS. And this result was similar to a previous study by Chang in 2019. We said that the stable range was 1 to 5 millimeter. However, the most previous study shows that there's no significant impact of OGS, significant impact of the mesothelial advancement amounts. However, their study was mostly the small case numbers. And another factor was the function, which means the muscle function for the VP port closure. Then in the Phillips study in 2015, they found that it is a significant factor for the development of VPI. And they highlight the need for the functional evaluation by a routine NPS for every patient before OGS. And then we want to talk about 2-jaw versus 1-jaw OGS. The advantage of the 2-jaw OGS is that the 2 jaws can have the mandibular step back to correct the mandibular prognathism, especially in the Asian cleft patients. Those patients mostly have a cleft removal cushion. So combine the upper and lower jaw, the 2-jaw surgery, the mesothelial advancement was amount was limited, and it also can improve the MMC relationship. So it has the less chance of VP worsening and relapse. And the VP worsening rate in this study was 40%. And comparing to the previous literatures, range from 8 to 36%, we think was our BP worsening rate was below the average. And also a study by Imperi in 2018 says that seems factor to be, however, that didn't give any comprehensive explanation about this finding. And finally, the 2G OGS has a better facial appearance improvement compared to the 1G OGS. And on the other hand, the disadvantage of 2G OGS is that the risk of developing a sleep disorder because of the mandibular setback. However, they were lacking of the comparative study of the comparison of 1 and 2G OGS. And this table shows the literature review of the recent study, which with the case number greater than 25 in the recent about more than 20 years. And our study is here, and we have the largest case number, and we do all our case was the 2G OGS. And our mean message advancement amount was 3.3 millimeter, which was below the average compared to other studies. And also our study answered 3 questions. The first is that the OGS did worsen the VP function after the operation, and it has the statistical significance. And the VP function worsening rate was 14%. And also when we advance greater than 4.27, it will have high risk for VP function worsen. And we have a special issue is that the improved VP function after OGS. We have six cases in our series. And this 6 patient has a pre-OGS VP function marginal. And we calculate the message advancement in the VP improving group. The message advancement was 2.6 millimeter. And in other group with the VP worsening, the advancement amount was 4.0. And we think that the difference of the message advancement in these 2 groups may also have some influence on the velopharyngeal space. So we further calculate the velopharyngeal width based on these 2 lines. The first was the proposed PNS to the posterior pharyngeal wall, and the other was the uvula to the posterior pharyngeal wall. So we also have the supplement data like this. And first, we can see the pre and post OGS comparison. The velopharyngeal width significantly increased in VP worsening group, and which has the significant difference. However, in the VP improving group, the pre and post OGS velopharyngeal width didn't significantly change. And others, when we do the group comparison, we found that post-OGS velopharyngeal width was significantly wider in the VP worsening group. And interestingly, we didn't find any difference in the pre-OGS situation. So in other words, we can't predict the development of the VP function worsening based on the to be safe. So in this topic, we need further effort to try to find any other, predictive factor based on the 2T safe. Another was the sleep disorder after OGS. We have 4 cases, and 1 was OSA, and 3 was snoring. And what to notice is that the mandibular setback in these 4 cases was 7.3 millimeter, which was greater than our average 4.5 millimeter. And this reminds us when we do a very extensive mandibular setback, we have to be cautious about the development of the sleep disorder after OGS. So in summary, function worsened after OGS. We found message advancement at function. And the RC curve analysis, we found that the message advancement was like 4.27 millimeter to have the VP worsen. And also the VP function is possible to improve if the massive advancement is not too much. And finally, we have to be cautious about sleep disorder and doing the 2-jaw OGF. So that's my speech, I think.
Thank you, Dr. Su, for your presentation. And now, without further ado, I would like to invite Dr. Sol for a comment. Dr. Sol.
Hello. Hello, Dr. Junior.
Hey, good to see you.
Thank you for introduction. Yes, this topic is quite interesting topic for me. When I got the training on the Professor Law, in the Monday meeting, we discussed about this topic before, and we didn't make a clear conclusion at the time, as I remember. So, actually, clinically, I believe that the just around 4 millimeter advance is sometimes not enough for the cleft patient for their more extensive maxillary hypoplasia, right? So, in my practice in Korea, usually the amount of the maxillary advancement is more than 7 or 8 millimeter, sometimes around 10 millimeter. So yeah, sometimes huge advance is needed. But after orthognathic surgery, when I asked to the patient about the voice change or checking the VPI incidence, just in my practice, not as much as like Professor Law, but initially they feel like some hypernasality initially, but as time goes by, after a few months later, the hypernasality is getting, the tendency is getting decreasing, and their voices also some get adaptation as I feel. So I don't know if, according to Dr. Su, your conclusion, so you suggest that when we plan the orthognathic surgery for the cleft patient, the amount of the maxillary advancement should be below under 4.27 millimeters for prevention of the VPI, right?
Yeah. Thank you for your questions. And yeah, I have 2 things I have to mention. This study further highlights the advantage of the 2-jaw surgery. So when we do the 2-jaw surgery, we don't really need to advance that much of the maxilla compared to when we were doing just a 1 jaw. We can have a compensation by the BSSO. So we don't really need to advance that much. And other things that this 4 millimeter was documented by the 6 months post OGS safe. So which means that when we do the surgical planning, maybe during the surgery we advance much than this 4 millimeter, and they have some small relapse. So when we do surgical planning, we can have maybe a little bit more, and this might be based on every surgeon's experience. Yeah, that's I think.
One more question I have. So according to your presentation, your the method of the VPI range measurement is just 2D based, right?
Yeah,
so
yeah, 2D. Yeah.
Measure the 3D measurement for the velopharyngeal area measurement, right? You didn't.
Yeah, we don't have the 3D to evaluate the volume. Yeah.
Because I also have I also wonder that how about the change about the lateral pharyngeal wall movement after orthognathic surgery. So it could be also discussed through this study for document about the velopharyngeal change after orthognathic surgery, I think.
Yeah. I think Dr. Joe has some study like that.
Really?
Yeah, okay.
Is that really?
Sure. I probably can answer these questions. In the cohort of our patient with cleft, and we divide it into 2 groups. One is the unilateral, the other one is bilateral. Prior to the 2-jaw orthognathic surgery, we measure 3-dimensional the velopharyngeal space volumes. Preoperatively, the bilateral group has less and smaller the velopharyngeal space volume than unilateral groups. However, after the 2-jaw surgery, including the level 1 in the BSSO, after the surgery, the post-operative, the velopharyngeal space volume is almost the same. The improvement is significant in the bilateral cases. And no difference in the unilateral cases. Yeah, this is so far the study's findings. Thank you. I have to apologize. In the very beginning of this webinar, I forget to introduce our very important friend. And the one is the Professor So, and the one is Professor Sola Yu. Professor So coming from the Korean, and he is our very good friend and focusing on cleft management, the surgery in PNUH. And thank you for bringing a lot of our friends from PNUH today to join the webinar. And by the way, is Professor Sola Yu is our fellow in 2016, and he's very famous in the Thailand cleft surgeon. Professor Sola Yu is here with us. So this is my supplement pay my compliment for you. Yeah, Dr. Junior, please go ahead. Thank you.
Okay, thank you, So, for your comments and your questions. And now I'd like to invite Dr. Sarah Hughes. Sarah Hughes.
Yes. Hello,
Yes.
Junior.
The floor is yours, so take it away.
Okay. Okay. And so, first of all, thank you for the Chang team to inviting me to be a panelist in this session. And thank you, Dr. Su, for the very informative presentation and informative study about the VP function after the OGS. I just want to mention or share my experience that in my hand, your study is quite interesting that we have already created the cut point about 4.27 millimeters to keep in mind for the planning of the maxillary advancement. This is very informative information that most of the study have never mentioned about that. So after listening to your study, maybe I have to warn my patient that if you want to advance the maxilla more than 4 millimeter, maybe you have some negative impact with the VP function. But I want to share my experience that when I was back to Thailand, to Bangkok, usually my average maxillary advancement for the cleft patient is around 4 to 5 millimeters. And I always ask the patient post-op after surgery that if they have, if they think that themselves have a negative impact on the speech function. But interestingly, I got no patients mention about the bad speech after the operation. So and in my own experience, I have never faced the patients with a post-op VP function. It's maybe because actually from the nasometry or from the endoscope, maybe there's some negative impact, but in clinically, the patient have never mentioned it. This is one of the interesting point of my experience. Yeah, and another interesting that I have listened to some of the Thai surgeons that they usually do the DO, the distraction osteogenesis in the maxilla. So I think this is the very interesting spot or the topic that we have to study more. If the maxillary DO have the same impact on the VP function or have a different impact on the VP function as well. So I have 2 points of comments. Thank you.
Thank you.
Okay, thank you, Sarah Hughes. Now, before we move on to the senior author, Professor Low, for comment, I'd like to invite Dr. Fayyaz for his experience on this matter. Dr. Fayyaz, are you available for a comment?
Hello.
Hello.
Can you hear me?
Yes, we can hear
Yes.
you well.
Hello,
Yes.
Professor Fayaz.
Yeah, actually, I would agree with the conclusion of the speaker that whenever we advance the maxilla more, the VP function is definitely affected very badly. So the most important point is whether the patient before OGS has good VPI function. If he has good VPI function before surgery, the negative impact would be less. But if the patient has already compromised VPI, the negative impact after OGS would be greater. That's my comment.
Thank you, Dr. Fayaz. And now, last but not least, I'd like to invite Professor Low. Professor.
Yes, hi, Dr. Su, can you go back to the slide with the bar chart showing the before and after? Yeah, the bar chart.
Okay, sure.
Okay, I think this result is quite interesting that before the surgery, patient with adequate VP, they about 20% develop VP deterioration after the OGS. I think this is quite a regular finding compared to others in the literature. Certainly on the right side, patient has inadequate VP function before the surgery. They all remain the same, which is inadequate VP function. Now, very interesting is in the marginal group that majority still remain marginal VP function, and 3 of them become worse from marginal to VPI. Certainly, this is a small degree change, but also the patient will receive the similar VP surgery as the next stage after the OGS. Just very interesting to find this 6 of the marginal VP patient, they become adequate after the surgery. So two-jaw surgery with lipid advancement and mandibular setback, they actually change the VP function in a different direction. And this is very interesting part in this study, because most of the previous report in the literature, they mainly focus on the forward advancement, the single jaw surgery. But because two-jaw surgery is very popular in Chang, we almost routinely do two-jaw surgery. And I think this tendency is has become popular, that more and more surgeons, I think especially the young surgeon, they prefer to do two-jaw surgery, because in our hand, we feel that two-jaw surgery not only improve the dental occlusion, but also improve the facial aesthetic, facial appearance. I think this is the most important part. And that's why we actively do two-jaw surgery. And here in this study, we do find that VP function could become worse, but also could become improved. So this is a very interesting finding. And also at the same time, we also found that a small percentage of patients, they develop sleep dysfunction, i.e. snoring, or even one become obstructive sleep apnea. This is mainly also caused by the mandibular setback that result in narrowing of the VP space. So I think perhaps this figure is the most important part in this study. Now, I would also comment on the data of 4.3 millimeter. I personally, I would not pay attention to this data, because it's just showing that in this study that 4.3 millimeter maybe is a pivot point that the VP could become worse after the OGS. However, when we do the OGS design, nowadays we mainly use three-dimensional simulation. I think we should focus on the facial aesthetic change. Okay, that means you need to pay attention to SNA, SMB, AMB, or maybe more importantly, the A point and B point in relation to the M vertical. That help to improve the facial appearance after the OGS. I think this is also a very important point when we design the OGS. So certainly patient with more retruded maxilla, you should be, end up to advance the maxilla more than patient with just a minor prognathism. So I think when we do the design, we should focus on the facial aesthetic. Certainly, dental occlusion is the first part that we need to focus on. So in terms of the facial aesthetic improvement, we do a lot of MMC clockwise rotation. That is to increase the occlusal plane. So by doing this, we could change the relationship between A point and B point, that is A and B or A point and B point in relation to the M vertical line. So in terms of the design of OGS, I think it's very important to focus on the facial aesthetic improvement. So this 4.3 millimeter data is just to show that if you over this data, maybe this is information that you need to discuss with your patient during the preoperative consultation. So and also this is the finding from this large cohort study, very interesting data. Now, Dr. Sarayu mentioned destruction. I would like to ask Dr. Sarayu to talk about destruction. I didn't hear clear. What do you, when you say destruction, what do you mean by destruction, Dr. Sarayu?
Yeah, yes, Professor Low. So actually, I do not do the destruction myself because when I was trained in Changgang for 3 to 4 years ago, and I came back from Changgang, I follow your algorithm or your rationale that usually I do the one stage maxillary advancement, but there is some maxillofacial surgeon in Thailand. He loved to do the distraction osteogenesis. Let's say that even 4 to 5 millimeter of advancement, he will do the DO. So that's why I have a question about that. If the DO will give the less negative impact on the VP function or not? That is my question.
Well, recently we do not do maxillary destruction a lot in Changgen. Okay, maybe I should say that it's very rare to do destruction in patient with cleft, because we can easily manage with maxillary forward and mandibular backward, and in order to change the occlusion and the facial aesthetic. However, if you have a patient who before surgery the overjet is very negative, for example, minus 25 millimeter, then you may end up with moving the maxilla very much forward and then mandibular very much backward. And that, if you feel that that could induce some instability, then I think in that situation, we may consider to do maxillary destruction. I do have a case that I plan to do maxillary destruction because the preoperative overjet is so much huge different that I don't think that I could do one stage of two-jaw surgery that correct the problem. You know, I even tell the patient that, hey, can we do two times of OGS? I do one time, it relapse, I do another time. Then I rule out this option because the patient has very weak bone. And so I don't think that it's a good idea to do 2 stages of OGS. Certainly, if I can do 2 stages of OGS, that could be better than destruction, because destruction, you will wear the halo for a long time. And maybe you also need to do mandibular surgery as a second stage. So you may need to balance this judgment or planning according to your preference, your environment, or patient's discussion with the patient. Now, destruction, whether it will result in less influence of VP function. This is interesting question, okay? Because previously, many people feel that if you do destruction, this is a gradual advancement. So the influence, negative influence to VP function should be, theoretically, should be less. But this, based on our previous experience, because in 1995 to 97, we are very actively doing destruction. When Dr. John Pauly, Dr. Figueroa, they came to Chang and to to discuss with us to do the maxillary destruction, gradual destruction, and we are very actively do a group of patients. We do find that in the patient with destruction, the speech function becoming worse also is very popular. It's very popular. It doesn't prevent the VP deterioration. So that's will be my answer regarding the destruction.
Thank you, Professor Low. Now, I think our panelists have commented. So I think we'll go to Q&A now. Now, first question is from Dr. Shetty, and she asked, she wants to ask Dr. Su and Professor Low whether the OSA patient was, how the patient was treated after the OGS case.
I cannot remember this case. Dr. Su, do you have data on this case?
Actually, the OSA case was just one case, and I didn't remember. I think we didn't do the redo surgery, and maybe just some conservative treatment. I think I didn't remember.
But I can tell you that if the cleft patient have OGS, most of the time they have a pharyngeal flap. So what I will do is to divide the pharyngeal flap and sometimes slightly shorten the soft palate, and that will be my answer, because patient with obstructive sleep apnea with adequate speech function, but they prefer to have good sleep. So I said, okay, I divide the pharyngeal flap for you. The speech function may become worse, but if they understand, I would do that. But actually, for adult, even we divide the pharyngeal flap, the speech function the sleep function may be improved, but the speech function majority still remain adequate, remain the same as before division.
Okay, and for our next question, we have a question from Dr. Yang. And his question is that for patients who have already previously undergone VPI surgery before, will the effects of OGS on VPI change? is there any difference for patients who have already received velopharyngeal before?
No, our studies show no influence on the previous VP surgery.
So
Yeah, even, yeah.
Whether the patient has received VPI surgery before or not, it basically, the only thing that matters is how the VPI condition is prior to the surgery, right? So
yeah, that's right. Yeah.
Professor Lo, do you have anything to add for this question?
No, I actually the protocol in Chang is that we will treat the VPI two timing. One is the preschool age, and the other is at the time of ABG, alveolar bone graft, which is 9 years of age. Because 8 years, 7 year, 8 year, they have adenoid involution, so they may develop VPI. So during the alveolar repair, we will do the VPI surgery at the same time. So pretty much most of the patients remain so-called acceptable speech function. Certainly when they become older, teenage, or approaching the skeletal mature, if they show any sign of VPI, if it is not significant, I would prefer to wait until they reach the age, and then we do OGS. And then after the OGS, we will do everything else, including lip and nose revision, VP surgery, or even residual oral nasal fistula as the second stage. So this is currently the protocol for the patient with cleft.
Thank you, Professor Lo. I have a question to ask Dr. Sarah Yus and Dr. So regarding the VPI, the testing for VPI. Do you guys do it at similar ages, or do you guys have a different protocol?
Okay, maybe I'll answer first. I think I do the similar protocol from with the Chang protocol.
Yes, in our hospital also almost similar with professor's protocol. My senior professor ran straight treat the cleft patient, and mostly he wait until 4 years before confirming another treatment plan for the VPI. And before that age, he usually wait, and mostly the protocol is quite similar with Professor Low. Thank you.
Thank you. Dr. Fayyaz, what age do you guys test for VPI? Oh, Dr. Fayyaz, you're on mute.
Yes, our protocol has been to assess the speech usually at 3 years of age. But if we feel the speech therapy cannot improve the speech and we want to do VP surgery, the minimum age we do pharyngeal flap is 4 years of age.
Thank you.
Good. Actually, Junior, I have one more question. It's
Okay.
for our panelist and Dr. Fayyaz. So by the way, for those cases to doing the orthognathic surgery with the pharyngeal flap, would you doing the division of pharyngeal flap immediately along with the orthognathic surgery, or you will follow up how long is the period to observe the speech function to decide if the pharyngeal flap will be divided or not? So what is your experience from Korea and Thailand, and Professor Fayyaz, please?
For me, I never do the pharyngeal flap division before the OGS, because I think I can move the maxilla with my plan. So I have never been in the experience of division of the pharyngeal flap, but maybe some others panelists will have some experience. Thank you.
I don't have any experience of dividing the pharyngeal flap during or before or after OGS. I don't have that experience.
Thank you.
Yeah, actually, I don't have experience, but I heard several cases from my mentor, Professor Beck, and he had several cases due to patients' symptom like falling by the sensation or snoring, that kind of problem. And interestingly, Professor said even though he divided the pharyngeal flap, the velopharyngeal insufficiency doesn't happen. So he also sometimes he also mentioned about that. It's quite interesting, yeah, result, like Professor was mentioned. Yeah. Thank you.
Okay, thank you very much.
Okay, and for our next question is from Dr. Zaw. Dr. Zaw wants to ask whether the SARPE or MARPE change the voice of the patient. Does Professor Low have any experience regarding the the expanders?
Can Dr. Zhao explain the SARPE and MARPE?
I think she meant surgically assisted rapid maxillary expansion. And then the MARP is the mini screw assisted expansion.
That I don't have the experience. I may have to ask our orthodontist.
Yeah. Does anyone have any experience regarding this? I think this is more orthodontic oriented question. And since we're the panelists here today are all plastic surgeons, so we don't typically deal with this type of procedure.
Yeah, but I actually could say something that the patient after after the OGS, in my experience, they usually the voice remain pretty much the same 6 months after the OGS. Beginning immediately after the OGS, many patients reported speech change or voice change, but gradually when they get adapted to the new environment, new tongue environment, oral function environment, they gradually become back to the previous speech and voice.
Okay, thank you, Professor Low. And for our last question is from Dr. Shetty again, and she wants to ask if the patient is presented with OSA post the OGS procedure, would you do a soft palate shortening procedure or a genioglossus advancement procedure?
Well, when I do the OGS, I actually most of the patients may receive genioplasty together again. Okay, so I would not do again the genioglossus this kind of management, because I already have the genioplasty advancement already. Regarding the OSA after the obstructive sleep apnea after the two-jaw surgery, because really very few patients, I cannot remember, maybe that single case reported, so I have to go back to see what happened to that single case. In my memory, really, our patients do not complain that their sleep become obstructive, that we have to do a sleep study to document the obstructive sleep apnea. But if the patient still complains sleep problem, what I will do is to look at the nasopharynx, oropharynx. If patient have pharyngeal flap or patient have sphincter pharyngoplasty, and I will enlarge the VP port by dividing the pharyngeal flap, or by cutting the two posterior pillar in order to enlarge the VP pose to improve the function. And occasionally, I would do UPPP to shorten the soft palate, just to excise some of the tissue anterior to the uvula, and then suture it back to shorten the soft palate.
Thank you, Professor Lo. And Dr. Cho has a question directed to Dr. So. What scenario of cleft would you decide to do a 1-jaw or a 2-jaw OGS for the patient?
Thank you for question. Mostly I prefer 2-jaw OGS for the patient because like Professor Rose mentioned that not only for the cleft occlusion and for changing the facial profile, so 2-jaw surgery is more helpful. Even though the 2-jaw surgery can collect not only the lateral profile, also change some of the asymmetric collection also. So 2-jaw surgery is more, in my case, 2-jaw surgery is more helpful for the patient. That's the reason why I prefer 2-jaw rather than 1-jaw surgery.
Dr. Sarah, do you have anything to add for your own experience?
Yes, most of the patients, I will do the 2-jaw surgery because most of the patients they have both of the maxillar hypoplasia and mandibular prognatism. So I will measure the SNB for the mandibular position. If the SNB is more productive, I will do 2-jaw. But if the SNB or the position of the mandible is in the normal range, I will go back to the maxillar advancement. If the maxillar advancement distance is quite high, I will do 2-jaw. I have to say that in my experience, after I come back to Thailand, I do 1-jaw surgery. I mean the maxillar advancement in the cleft patient in only 1 patient. So 95% of my cases, I do 2-jaw surgery. Thank you.
Okay, thank you, Sarah Youth. Okay, if there are no further questions, I guess we'll end the Q&A here. And just before we end the Q&A, I'd like to ask everyone to fill out the ICC webinar questionnaire form for us to give us a better feedback of how we should manage the ICC webinars going on. Okay, thank you. And Dr. Zhou,
Yes.
back to you.
Thank you very much, Junior. We have very beautiful time here with all our panelists and our audience, and thank you, Professor Fayaz. Always, I would like to invite all of you to show your beautiful smile with us. Please to turn on your screen to let me see what's going on recently from our friends. Thank you very much. And thank you, Professor Handa. Thank you, Professor Tamada, and then thank you, Professor Nobu. Hi, Hattori, how are you? Yeah, good to see you guys. Thank you, Professor Jordan Stenberg. You're always our very important support. Okay, I will count to 3 and then please show you a smile. This is the group photo for the very unforgettable memorial. Okay, 1, 2, cheese, and 1 more, please. And probably you can give me a small heart or give me any gesture like a fist on your face, anything. Okay, 1, 2, cheese. Okay, thank you again, all the professors. Today we have a very beautiful and a very deeply discussion in the topic of velopharyngeal function in the cleft. Remind all of you, thank you. We have a very important 2 speakers in November. One is Professor Somerlade. One is Professor Hoopers. They were talking about very important issue, the cleft palate repair. And Harper, we are talking about how to treat the treacle Collins patients. Looking forward to your participation in the future. And thank you very much for your join. Have a good day. Have a good night. See you. Bye-bye. Thank you, Sarayu. Thank you, Saul. Thank you.
You're
Fayaz,
welcome.
Professor.
You're welcome. Thank you.
It's good to see you again, Sarah Yus and Dr.
Yeah,
Take
it's
care.
good to see you again, Junior.
Thank you.
Hope to see
Yeah.
you in person
Yeah.
soon.
Yes.
Yeah, I will
yes.
next year.
Hello,
Okay.
bye.
Next year. This
Next
year,
year.
please.
Next year, please, bye.
Bye bye.
Bye-bye.
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 Good night.
Thank you, Chun-Lin. Yeah, you did a great job.
Thank you. Bye-bye.
Bye-bye.
Bye.
Okay, thank you, Junior.
Okay, Xiang, bye-bye.
Okay, 谢谢，拜拜。